to Dr. Fetty for the invitation to speak about the updates in contact lenses for myopia management. It's an honor to be here today all the way from Jacksonville, Florida. I joined Johnson & Johnson about 1.5 years ago, and I am the Global Professional Education Lead in myopia. I was previously working at the Brian Holden Vision Institute and also at the International Myopia Institute, where I led the development of key white papers in the field. Here are my disclosures. I'm an employee of Johnson & Johnson Vision. I was part of the Holden et al. 2016 study that first reported that myopia is estimated to affect 50% of the world by 2050, or close to 5 billion people. 10% would be highly myopic and at risk of things like myopic macular degeneration, glaucoma, cataracts, and retinal detachment, and will require comprehensive eye care service. Myopia is increasing steadily, but the prevalence of myopia is doubling every 20 years. In Europe, the prevalence of myopia tends to be less than other parts of the world currently. In Central, Eastern, and Western Europe, myopia prevalence is averaging about 30% by 2050, and it ranges from 50 to 56%, similar to the prevalence of East Asia on average today. This snapshot of the world shows that East Asia is where the prevalence of myopia has reached epidemic proportions of about 80 to 97% of young males, as well as university students. Myopia is also increasing in the West, with a recent population-based study reporting prevalence of 24% in French young adults in 2018. We can see the prevalence is around 50% in places such as the UK, Germany, and US. During the COVID-19 lockdowns, myopia prevalence increased in many parts of the world. In China, it actually increased 3 times, and it is suggested that the lack of time outdoors and intense near work may have been a key factor. We have time to change the trajectory of myopia, especially in places such as France and in the western part of the world, where prevalence today is still relatively low. The WHO first recognized myopia as a serious public health issue in 2015 at the WHO BHVI meeting in Sydney, where we had 34 experts representing each WHO region. The chairs of this meeting were Professor Brian Holden and Professor Serge Resnikov, the former Deafness and Blindness Prevention Head of Department. I was the scientific secretary of this meeting and helped to lead the writing of the report that was eventually published, titled The Impact of Myopia and High Myopia, putting forward the first set of recommendations for definitions of myopia, high myopia, myopic macular degeneration, as well as guidelines for research and clinical management. To keep advocating and educating about myopia and to also bring the urgency to the rest of the world, we established the International Myopia Institute Working Group to bring together over 100 experts in the field of myopia, ranging from science to clinical to public health, to publish white papers in different topics in over 14 languages to provide guidance to practitioners and educators. You can find these white papers on the International Myopia Institute website, and you can download these freely. In some groups, myopia is being considered a disease because once you develop myopia, it tends to progress. There is excessive axial elongation, and there is risk of associated sight-threatening complications in addition to the negative powered refractive error. Bullimore and Brennan have reported that every diopter matters, and that's because every 1 diopter increase in myopia increases the risks of retinal detachment by 30%, cataract 21%, and primary open-angle glaucoma by 20%, while myopic macular degeneration is increased by 67%. Now, myopic macular degeneration is an incredibly serious condition when it does happen, and that's because there's currently no cure and it leads to permanent vision loss. Now, if we can slow myopia by at least 1 diopter, it's been demonstrated to at least reduce the risk by 40%. Mental health is also an important part of people's lives and can really contribute to quality of life. Now, this study reviewed 36 different papers that were observational as well as interventional and looked at the causes of vision impairment in children and their association with depression and anxiety. And what they found was that myopia really is strongly associated with higher scores of depression than normally sighted children. Now, when myopia is not fully corrected, it can also impact learning and education. And the children with myopia were also concerned with their appearance when corrected. So the authors highlighted that it's important to detect and treat childhood vision problems for better perceived quality of life. Today, practitioner concern over myopia is increasing globally. A recent survey conducted by Professor James Wolfson was looking at the myopia management practices around the world. 3,195 eye care practitioners were surveyed across 21 countries. Now, in Europe, 800 eye care practitioners were surveyed, and they reported that about 6.6 to 7.9% of practitioners were offering myopia management, and that the most perceived to be effective treatments were combination therapy, followed by orthokeratology and pharmaceutical treatments. Now, in 2022, the survey reported that single vision spectacles are still the most prescribed option for progressing young myopia at about 32%, but this has decreased since 2019, so that's good news. Now, myopia control spectacles are now being prescribed about 15% of the time, myopia control contact lenses 8.7%, and combination therapy at 4%. These figures show the global level of concern versus the level of concern seen across Europe. Now, the level of concern in Europe was rated 8 out of 10 compared to other parts of the world. So, you know, in Europe, you are very concerned about myopia, considering that in Asia, they've ranked it a level of concern of 9 and North America is 8.2. So in general, everyone is concerned. Now, within Europe, the French level of concern was about 7.5 compared to the highest level of concern seen in Russia at 8.7. So now let's move on to the science behind contact lenses for myopia management. Now, all optical treatments slow myopia by bringing the retinal image forward in front of the retina, providing myopic defocus towards the periphery. And this has demonstrated to slow eye growth in animal models. And there's also many human clinical trials in children which have demonstrated that there is clinical efficacy with myopia management treatments. The current evidence does not support undercorrection, overcorrection, or no correction. And that's because it does leave children blurry and it may increase the risk of myopia progression. A very important point to make before we proceed to compare the different treatments is that percentages are not the best way to describe or compare treatments. And that's because studies are conducted at different times with different populations. And so the percent you're going to see reported is actually percent against the untreated group within a study. And so you have different untreated groups across different populations, allowing difficulty to compare. Now, if you do have to compare, then using the direct comparison of axial length, slowing is better. Axial length is also a more direct measure of eye growth. And axial length is also what is associated with increased risk of disease. This figure shows the change in axial elongation up to 3 years for all the myopia control trials. Pink are the Atropine studies, green are the orthokeratology studies, blue are the myopia control spectacle studies, and red and purple are the different soft contact lens designs. Now you can see within each category, there's a range, but if you look at the best performing of the ORTHO-K, the best performing of the soft contact lens for myopia management, and the best myopia control spectacles, they do provide similar efficacy. The takeaway from this is that all treatments show the greatest efficacy in the first 2 years. And then after that, the rate slows, but they do continue to provide treatment. So choose the treatment based on the patient clinical and lifestyle factors. And Brennan called the change in axial length care, which is the cumulative axial length change, or the total change in axial length over time. And this allows us to compare between treatments more accurately than using percentage alone. Now let's look at the science between the individuals. Now, ORTHO-K lenses are special rigid gas permeable lenses known as reverse geometry lenses with 4 or 5 zones traditionally, and have been studied in hundreds of Asian children for the past 15 years, and some have approval for myopia control. Now, it tends to correct up to -4.50 diopters easily and about -2.50 diopters of astigmatism, depending on the design. Now, some designs are approved up to -6 diopters. Now, ORTHO-K reshapes the eye overnight temporarily so that during the day, no lenses are needed to see. It does this using the fluid dynamics of the tear layer under the lens, and the myopia control effect is thought to come from the central corneal flattening leading to the mid-peripheral steepening that provides the myopic defocus. Orthokeratology has had the most studies published about it, and a lot of the studies have been done in mainly Asian children, but hundreds of children have been studied. Now, a meta-analysis looked at 7 studies and reported an axial length control effect of 0.27 millimeters over 2 years. It's not possible to report the refractive control because ORTHO-K leaves the person emmetropic. So only the axial length outcomes are shown here. So it's fairly consistent. And we've got studies out to 7 years now demonstrating a slowing of axial elongation of about 0.46 millimeters. ORTHO-K has also been demonstrated to slow myopia in high myopes as well as those with astigmatism. So Professor Pauline Cho did partial correction of high myopia of -5 diopters or worse using ORTHO-K, and they found that high myopia patients actually did benefit, and in this group their myopia was slowed by about 63%. Now, in toric ORTHO-K, they looked at people with astigmatism of up to 350 diopters, and they were able to report that toric ORTHO-K lenses can slow axial elongation by up to 52%. Today, there are many clinical trials looking at combination therapy. In other words, combining an optical treatment with a pharmaceutical treatment. And there have been very early studies reporting the effect of combining orthokeratology with low-dose atropine of about 0.01% most commonly. Now, they've done a study that combined all these different studies and looked at the overall effect. And the authors have reported that it's still the early stages, but it appears that efficacy of ORTHO-K alone seems to be similar to 0.02 to 0.025%. But when combining ORTHO-K with atropine, 0.01%, it seems to enhance the myopia control effect. Now, this doesn't mean that, every person should be getting combination therapy. We should just wait and see what the data suggests with longer term studies. In the soft myopia management contact lens category, there are a number of different designs which all result in different levels of slowing of myopia, and also various differences in vision quality. Now, I was at the Brian Holden Visual Institute at the time of this study, looking at the peripheral plus versus the enhanced depth of focus contact lenses. So in this study, there were single vision contact lenses used as the control group against 500 Chinese children and these 4 different myopia management contact lenses. There was a +250 diopter and +150 diopter multifocal soft contact lens versus the enhanced depth of focus, +1.75 and +1.25 diopters. Now, enhanced depth of focus incorporates higher order aberrations into the lens, and then it results in a global retinal image quality that is better on and in front of the retina, and the retinal image quality, global retinal image quality, degrades behind the retina, so the eye tends to prefer the better retinal image quality and slows axial elongation. So over 2 years, the rate of slowing between the enhanced depth of focus and the myopic defocus was not significantly different from each other. but better than single vision contact lenses, as you can see on the table in this page. So in blue, those lines represent the peripheral plus and the EDOF contact lenses, and in brown, it's the single vision control. So all of the control lens, the test lenses actually perform better than the single vision contact lens and not clinically significant within each other. Next, we come to the BLINK study, which was done in the US on 294 children with myopia over 3 years. And in this study, they compared single vision versus the plus 150 diopter ad and the plus 250 diopter high ad. Now, the high ad provided much better control than the plus 150 diopter ad, and it does suggest a dose response. So the higher the ad, the greater the efficacy. And we do tend to see that in other studies as well. The next design is the dual focus, which has central distance correction zones with alternating zones of distance and plus 2 diopter ads, providing the myopic defocus. So you have image focused on the retina and in front of the retina at the same time. In the first 3 years of this study, it was a randomized trial in diverse children and demonstrated that there was a slowing of about 0.73 diopters and 0.32 millimeters compared to single vision contact lenses. Now, in part 2 of the study, all the children were treated for the next 3 years, and the authors reported they found a similar rate of slowing overall after switching. And the ones that consistently were treated progressed at 0.18 millimeters compared to those who switched, who then progressed at 0.23 millimeters overall. So the study also reported that there was continued treatment effect over time. Now, I'm really excited to share with you a major innovation in optical design with the release of the RINGFOCUS technology, which does come from Johnson & Johnson Vision. Now, there is 6 months peer-reviewed preliminary data that has been published in an ophthalmology journal, which you can download using the QR code. The great news is today, we no longer have to compromise the amount of treatment power for the sake of vision. You can have high treatment power and maintain good vision. And that's because, you know, traditional multifocal type contact lenses would focus the image on the line of sight. So being on the line of sight, it meant that your visual acuity tended to deteriorate with increased ad power. Now, this lens itself has been designed specifically for myopia control and for children with its smaller diameter of 13.8 millimeters and slightly steeper base curve of 7.8 millimeters. Now, the RINGFOCUS optics you can see on the screen, they look like 2 rings, but actually they're almost like a donut shape sitting on top of the lens. So they're cut from a torus molded onto the lens. Now, this ring shape, these 2 rings split and focus the light using non-coaxial technology. And then they focus the light off the line of sight in a ring, a volume of light in a ring. And so we can engineer plus 7 diopters of treatment within this ring. And then there's the additional plus 10 diopter central dot boost that adds additional plus power. So the good news is the study results demonstrate that there is treatment efficacy over 6 months, and that the vision is maintained despite the high power in there. So the study of the RINGFOCUS technology was a multi-site, multi-ethnic, international, randomized, double-mask controlled trial, the most rigorous type of scientific study you can do. And 199 children aged 7 to 12 years were recruited, half of which were female. The children all had a spherical equivalent between minus 0.75 diopters to minus 450 diopters, and astigmatism of 1 diopter or less. The mean age was about 10, and you can see here the measurements taken were axial length, spherical equivalent of autorefraction, visual acuity, and vision quality, and patient-reported outcome surveys were done at each visit. So this is the 6-month study report. The study is still currently underway, and we have come up to 1 year of study. However, we only have the 6-month study to report. And here is our 6-month study results. Now it's incredibly exciting. You can see the figure on your left-hand side represents axial elongation, and on the right-hand side, you can see refraction. In green, it is the test lens, the RINGFOCUS, and in red, it is the control or single vision contact lens. Now here we can see that the difference over 6 months was 0.105 millimeters of slowing in axial elongation. And in terms of refraction, that was 0.22 diopters of slowing. Now this is quite significant over such a short period of time. And if we look at all the soft myopia control contact lenses available, you can see here EDOF lens provides about 0.37 diopters over 2 years and 0.15 millimeters of care or cumulative axial reduction in elongation. Dual focus design, 0.73 diopters per 3 years or 0.32 millimeters of care. Center distance multifocal with a high add, 0.46 diopters over 3 years or 0.23 millimeters, and RINGFOCUS technology, 0.22 diopters over the 6-month period with 0.105 millimeters of care. And the study is continuing on, and we hope to be able to, release study results in the near future. And we know that with soft contact lens treatments, we have now got 6 years of reported data in the literature. So, we can see that there is continued treatment effect in general with optical treatments over time. In general, any type of treatment increases the risk of potential complications. Now, with pediatric contact lens wear, there is always a concern for the potential for microbial keratitis. And so if people are using reusable contact lenses, they do need to follow disposal, replacement, as well as cleaning of accessories and things like that. But daily wear contact lens represents the safest mode of contact lens wear, and studies in children demonstrate that the risk is incredibly low. So educating children about safe contact lens wear and handling and frequent replacement is very, very important. Now, across all these randomized controlled trials of myopia control in children, you can see majority of the studies report 0 cases of microbial keratitis. And on average, the rate of microbial keratitis is 2.67 per 10,000 patient years of wear. And now in ORTHO-K, we know that extended wear can generally increase the risk of microbial keratitis just due to the fact that, the lens is being worn overnight. But there are now high DK materials for ORTHO-K that can definitely make it much more safer. And then children have been demonstrated to wear ORTHO-K quite safely as long as you go through education and handling once again and do regular follow-up appointments. Now, in the past, there was a study in the US that reviewed previous case records, and they reported that the incidence of microbial keratitis in ORTHO-K was about 14 cases per 10,000 years. Now, the recent study also by Bullimore et al. Looked at studies in Russia in children, and they reported that the rate of microbial keratitis was about 4.9 to 5.3 cases per 10,000 patient years. So it does represent a much more reduced risk of microbial keratitis, which is only slightly higher than daily wear of contact lenses. The studies do demonstrate that soft contact lenses and orthokeratology do have a place in myopia management. They can provide treatment efficacy that is comparable to other top myopia management options. In addition, contact lenses and ORTHO-K do have been shown to demonstrate improved vision-related quality of life. And that's because when children wear contact lenses and ORTHO-K, these studies have reported that children and teens feel more confident about their appearance. It increases their participation in activities, and that could mean sports and singing and swimming and debating. And children also feel greater satisfaction with their refractive error correction, so they're more likely to wear their refractive correction, which may have downstream benefits like, better participation and even potentially better learning impacts. At the same time, another study reported that ORTHO-K may result in an increase in the time spent outdoors, and going outside has been reported to be very, very useful because going outside at least 2 hours per day can halve the number of new cases of myopia, as well as slow axial elongation. So going outside 2 hours per day is definitely advocated, but of course with sun protection. This is a summary of recommendations that were drawn from the clinical guidelines paper from the International Myopia Institute. So today there is the ability to delay the onset of myopia, and that's by sending children outside at least 2 hours per day. That has been demonstrated to halve the number of cases of myopia. And also, if we are monitoring children, we can look at their level of refraction, and if we see a hyperopia reducing over time or less hyperopia than expected for their age, then we could potentially diagnose presbyopia and give them lifestyle counselling. And once a child develops myopia, Muti and colleagues has reported that the child is highly likely to progress. And so once a child is diagnosed with myopia, the studies demonstrate you should not really be waiting to manage it because they're likely to progress. So you can offer myopia management treatments. And there are now today many treatments that are approved, CE approved or FDA approved, and there are also many studies that have scientific studies that back them. So there are myopia control spectacles, myopia control soft contact lenses, there's orthokeratology, and then some practitioners now are looking at the science and considering combination therapy, although today it's not something that's approved. Now, with any type of treatment that you provide a pediatric age patient, there is always the potential risk. So we do need to follow them up regularly, monitor them, measure vision, measure axial length, and then at the same time, provide lifestyle guidance, because minimizing those risk factors associated with myopia is also very beneficial. So giving them 2 hours daily time outdoors with sun protection, of course, reducing the intensity of near work is also very important, because intense near work and things like that have been associated with a greater risk of myopia. So personalize your myopia management. It's not about looking at the treatment and then just giving that to any child. Look at the child holistically, their clinical factors, their lifestyle, and what their preference and the patient and parent preference is. Are the parents interested in helping the child use that treatment, or do they want something that's more convenient and they can be hands off? So talking to the parent, having that conversation, understanding the needs, and then recommending the treatment is much better than just saying, you know, efficacy alone, given that the best of each category does perform similarly. Today, we know so much more about myopia, and perhaps the way we manage it should be more about managing it like it's an ocular disease, because it's chronic and progressive. We know from the studies by Brennan et al. That there is no safe level of myopia. Every diopter matters. And we also know from the studies by Bullimore and Brennan that the benefits of myopia management far outweigh the risks. We should consider trying to detect every child with myopia, providing the lifestyle counselling. And once a child develops myopia, we should consider treating them holistically. And that's because once a child develops myopia, their eyes continue to grow and the refractive error almost certainly increases. Now, with any type of treatment, consistent objective monitoring of patients is needed. And that's because they are young, they may be doing contact lens treatments or any other type of treatment, and so following them up is necessary. Axial length measurement is something that a lot of practitioners are now investing in. They are quite useful because they're objective, they're easy to use, and they're a direct measure of eye growth. However, if you don't own one of these devices, you can still do myopia management. And that's because accurate refraction is very useful for tracking myopia progression. And you can also just keep following them up over time. And we know the studies do correlate between axial length and spherical equivalent. And then once you develop your myopia management practice, you can invest in more nicer equipment that allows you to provide more diagnostic information for myopia management. Ultimately, practitioners play the key role to change the trajectory of myopia, and that's because you're seeing the patients, you're communicating with them, and you're advocating for them. And ultimately, you know, if you can provide better patient care with the latest technology, I think that's something that all of us optometrists are wanting to do, and that's what we do every day. So myopia management should be part of what we do. Thank you so much. And if you have any other questions, feel free to stay online and ask me. And here is my contact information if you want to get in touch. Thank you so much. And I really enjoyed being here. Bye. Au revoir.
Alors, merci beaucoup. Thanks a lot, Dr. Monica Jong. I think that it was a very nice talk about means that are now updated. The data seems to be very positive, and that should put us on the obligation of doing all the best to manage carefully but precisely myopia. I don't know if there is any question. Dr. René Combe is a French optometrist. He did his studies in Boston at the New England College of Optometry, and don't know he's working also on myopia. I don't know if he's well. I would start asking you about this new setup, contact lens setup, which is RINGFOCUS technology. So this is quite interesting, because in 6 months you got already good results. That means that if we carry on working with such lens, I think in 3 years we maybe do better than other designs, such as multifocal and so on. Let's see. Is it a daily lens, contact lens?
Yes, so this is a daily disposable contact lens in the Oasis material. So the reason why we want to make it a daily disposable is because that's the safest modality in terms of, any type of risk, because it's frequent replacement. And then the Oasis material itself is high decay. And then it's also known to be easy handling, especially for children. And then it also has the UV blocking in there. And so we have the study published in online open access for the RINGFOCUS contact lens. And the studies are still continuing, but we do have approval for this lens to slow myopia in places such as Canada, Hong Kong, and Singapore. So they are available there. They're just not available anywhere else because, it's us trying to get approvals. But in those countries, they have approval for myopia management and slowing of axial elongation.
Fine. I have actually already the article. I will share it in the FCU group so people can just download it and look at it, because it's quite interesting. I don't know if there is other people who are asking. I will see in the Facebook if there is any question.
I mean, the vision results are quite good too, as the paper reports that they're in the study, no children dropped out because of vision reasons. 95% of the children achieved better than 20/20, at least monocularly, with the contact lenses on. And the subjective vision was also quite comparable to dual focus contact lenses. So it's comparable in vision to the other multifocal soft contact lenses out there, even though we have that +7 diopters of treatment power in the rings, and then a +10 diopter central dot power.
Okay.
And no effect on binocular vision.
No effect on binocular vision.
Yeah, binocular vision stayed normal.
Fine. Actually, I have been reading about what has been done, and it's on the way to be done by BNG, and you are also working on ORTHO-K in some special specific design?
Well, I mean, Johnson & Johnson, I have to disclose, does have an orthokeratology product only in certain markets. The one that we have is licensed from Menacon, but it's branded as the Ability overnight lens. Now, this ORTHO-K lens has already been in existence in the market for 15 years, but J&J has launched their own brand of it, and it's available in the US, Canada, Hong Kong, and Singapore, and we will be looking to launch in other markets next year, including France, the ORTHO-K lens. So it's an existing ORTHO-K lens design. It's not something that we've created.
Okay.
Yeah.
And
we are investigating new myopia management and myopia control technologies because, you know, we believe that myopia management is about providing the best treatment. And so it's not about one product. It's going to be a portfolio of treatments in the long term. So, you know, we are working to have, you know, ORTHO-K and the soft contact lens and eventually other types of treatments to complement this so that practitioners who work with J&J or use J&J will be able to have the full suite of treatments available, and they just select the best one.
The last week, there has been an article about Atropine 0.01, and it seems that in the States, it seems that it's quite a puzzle because in the States, in the Caucasian population, there is no effect. They said that it's like a placebo. Have you any comments about that?
It is very interesting because, you know, there were other studies such as the ATOM study in Singapore when they did the 0.01% study. They didn't use a concurrent control group, but if you looked at the axial length data for the kids treated with 0.01%, they had a refractive slowing in myopia, but then the axial length slowing didn't correlate. There was very small axial length slowing. And then even in the recent times, there has been the LAMP study done in Hong Kong Chinese children, and they were not demonstrating a clinically significant effect in the axial length with 0.01% low-dose atropine. And then there's also been the recent CHAMP study that looked at low-dose atropine in white children, and the effect in the axial length slowing didn't appear to be significant either. And then now this study in the US is also reporting that it's not clinically as effective in the axial length slowing. So a lot of practitioners today are starting to use a slightly higher low dose concentration, such as 0.02 or 0.05%, because a lot of the LAMP studies and other Asian studies have demonstrated that there's been, you know, a better dose response effect, like you're getting better axial length slowing. And then it's also providing pretty good visual outcomes, so less adverse effects on the vision. So, I mean, this is still a treatment that is considered off-label because in most places, low-dose atropine is indicated for other things, but practitioners are just deciding to use it for myopia control because of the studies. So I think like as practitioners, I think most of the evidence suggests that probably you should be choosing to use a slightly higher low-dose concentration.
We have Dr. René Kong.
Yes.
Have you any comment on the presentation?
Yes. Your question. Thanks first for your presentation. You spoke about holistic treatment. I agree completely, totally about this approach as a functional optometrist, FCOVD. So what do you mean by holistic approach? Because so far, we can't read anything about it in the publication.
Yeah, it's because it's hard to do a clinical trial using a holistic approach, and that's why nobody has done that. But if somebody does a holistic approach, a clinical trial, that would be incredibly useful. to give us more guidance about how exactly we should be doing a holistic approach. When I'm discussing holistic approach, I mean, when a child comes in looking at their age, so if the child is younger and they've developed myopia, that means they're going to be at greater risk of faster progression, because we know that, you know, under the age of 9, they're probably going to progress even up to 0.75 diopters to 1 diopter per year, you know, if you develop myopia at the age of 6. So that means, you know, that child, young age, and their ethnicity. If they're Asian, then they're at higher risk of progression and faster progression. And in their family, if they have parents with high myopia, or they have lots of family members with myopia, then they have increased genetic risk at the same time. So looking at that, but then also asking the question, you know, what do you do in your daytime and nighttime? Are you sleeping enough? Because there's studies suggesting that there's increased risk of myopia with kids that aren't sleeping enough. It could be to do with, you know, the day-night cycle, or not going outside and getting enough dopamine. And if kids aren't going outside enough, then they're not getting a break from all the near work. They're not getting the effect of the light on the eyes, which is stimulating some kind of biochemical response that is seeming to slow eye growth down. Because when you go outside, it could be the dopamine, it could be the bright light levels. It could also be that the image is less blurry when you're outside. So there's all these effects. So considering all this, and then understanding, is the child interested? Are they interested in playing sports and activities? Because if they're very active, then we should consider something that, you know, a contact lens type correction or ORTHO-K. And are they mature enough to handle the contact lenses? If they know how to brush their teeth every day, look after themselves, or the parent is willing to help support them in contact lenses, then that could be a good consideration. So it's understanding all that, understanding the patient and the parent motivation. So there's not some kind of exact rule. So it's a clinical judgment based on the practitioner and their own experience and understanding of their patient. But we do know that from the studies out there that today, you know, we have regulatory approved treatments in certain countries, in certain parts of the world. But then there's also the scientific studies that now date back for things like, you know, there's new spectacle myopia control studies that now are about up to 3 years of demonstrated efficacy. Then there's the contact lens studies that we know have demonstrated up to 6 years of treatment efficacy, and ORTHO-K 7 years. So there's all these studies that demonstrate some clinical efficacy that we can also consider. But of course, you know, there's those challenges. You know, myopia control can take many, many years. So it's always like educating your patients and helping them to understand it's a long-term commitment. They may need to be managed up to the age of late teens or even early university days, and that the management may change depending on your lifestyle and your myopia levels and things like that.
Thank you.
Any other comments?
Are you doing
Renee?
myopia management in your school there, Dr. Combs?
Yeah. Yeah, I use all this stuff you described, and it's very interesting. And especially about the new product, RINGFOCUS. And if I understand very well, there is a high power, very high power, +7 diopter in the periphery. That's right?
Yes, correct.
Okay.
Yeah. But you know, it's still undergoing the FDA trial, so that's going to take a little while.
Yeah, of course.
I have read last week also about something interesting about some kind of focusing on the basic side, on the fundamentals of how myopia is, how kids can develop myopia and then can have a progression on myopia. It has been some kind of awareness awareness stout on Johnson & Johnson when they did a kind of seminar on looking at the mechanism at the level of the retina and what's the behind the apparition of the myopia, and it's increasing because we are trying to act on the consequences, and we know that the K for this problem is maybe some kind of mechanism which are underlying development in some kids myopia, and others they don't develop myopia in the same environment, and sometimes in the same family we have some. So what's going? You are kind of very involved in this field. What's new on how to the mechanism, biological mechanism on this aspect?
So you're meaning what is the potential biological mechanism when, you know, even within one family, somebody may have myopia, the other one doesn't?
Right.
Yeah, that's a question that a lot of us are trying to understand. Now, what is emerging is that genetics is not the biggest risk factor for the common myopia that we see today. Like the majority of the myopia we see is mainly because of the environment. Now, there's a few reasons for that. I mean, we know that, you know, it's not related to, we can't say at this stage that it's the screens or the devices use that's causing myopia or driving that, because the increase in myopia prevalence happened much earlier, decades before, you know, smartphones and devices happened. And there's been a lot of association studies that have shown some association between screens and myopia, but the evidence is not so strong that we can tell people stop using devices. I mean, it's good to limit your device use just from the health side and reduce the work near risk factor. Now, there's other studies that have looked at lots of genes for myopia. There are over 450 genes that are responsible for eye growth and can be involved in myopia. They've never found one single gene that directly, you can say, causes all the myopia we see today. Now, they've looked at all the genes and looked at the environment and did a calculation. These are called the environmental genetic interaction studies. Those scientists reported that the contribution of the genetics to somebody's refractive error is probably only explaining about 20%. So that's why a lot of this is coming from the environment. So even within one family, people's behaviors can be very different because behaviors can be linked to personality. So they may share similar genetics, but then you have some children who probably prefer inside activities more than others. Some children probably do more studies than others. And even with myopia in Asians, right? The prevalence of myopia in Asians in general is higher, but the level of myopia in Asians in Asia tends to be higher than the level of myopia in Asians outside of Asia in the Western countries. So it does suggest it's the environment and the culture is playing a huge role on this. But people are trying to understand about how this is happening at the level of the retina. So there's a lot of different theories, like you know, the retinal defocus and the blur is a stimulus to axial elongation. But then there's also the biochemical reactions along the way. So, you know, does dopamine release also modulate the eye growth? People are looking at inflammatory factors now. Some people are even looking at certain cone pathways even. So there's still a lot to understand, and people are looking at retinal blood flow like the choroid and things like that in, you know, changing the retinal focus. So we still have to understand a lot of things. For some reason, we know that we can change the eye growth by, you know, changing the focus on the eye or using a drug in the eye, but we actually don't fully understand what's happening at the level of the retina. So there's been, you know, you can look up the International Myopia Institute white paper on the animal models. So there's quite a lot of discussions about the theories in that. but we're all still trying to understand and work it out. And I think we all have to keep working together to do all those basic studies as well.
Okay, that's fine. Thanks a lot. Thank you for your answer. So I think that we have it's not no time to say goodbye, and thanks a lot again to Dr. Monica Jong. We are looking forward to see more publications on this RINGFOCUS technology and then other matters. So we are keeping in touch with the field. In the 17th of August, we will receive another diva of myopia control, Dr. Kate Gifford, which will give us a talk on new concepts on myopia control. Thanks a lot again, and
Thank you
see you
so much.
Thank you so much, everybody. I really enjoyed meeting you all.
Bye-bye.
Bye.
Bye-bye.
Bye. Thanks a lot.